السلام عليكم، اهلا وسهلا. انا احمد شيخ، مساعد جراحه العظام. سعيد بوجودي في مؤتمر جامعه اسيوط المره الثانيه. شكرا جزيلا لكل القائمين على المؤتمر حقيقه. الدكتور احمد اكرم طبعا السيشن دي هو اللي منظمها، والدكتور الشرقاوي والدكتور قطب وكل الناس وكل اساتذتنا الكبار في اسيوط. يعني في معزه خاصه برضو لاسيوط عندي. ذيس توك طبعا مفيش حد بيتكلم انجليزي، فممكن في شويه عربي في النص ولا في اي مشاكل؟ some okay. So it's Pillon fracture. It's beyond the plate. We all know that Pillon fracture can be fixed internally or externally, but there are some orthopedic dogma, which is some ideas that might not be so accurate. So my presentation here is about to uncover these ideas. I have nothing to declare, and this is the timeline of this presentation. So we talk briefly about the biology of the distal femur, fracture classification, history, evolution of the management of Pillon fracture, current evidence, and the systematic bias in the research at the moment that leads to this dogma, and the predictors of failures. And this last one is the big lesson of this lecture, that you should be aware of the predictors of failure to properly select your patient, and then you get successful outcome. We don't want to end up like this. This is the whole message. Biology, briefly, this paper has a wonderful drawing about the blood supply of distal tibia, and we can see simply that the distal tibia has the least blood supply and the least anastomosis of the whole tibia. So distal tibia is very special and very sparse in terms of the blood supply. And in this cadaveric study also, they found that the open medial plating disrupting the soft tissue more than the percutaneous plate. So there is still some privilege of doing MEBU, but again in the proper cases. But with open approach, this could be still very dangerous on the distal tibia blood supply. Classification, I'm not going through this deeply, but this is the Rodi-Algor classification. That's the old one, the first one, type 1, 2, 3, and then the AO classification, which everybody is quoting, and it's very clear and precise. And the whole presentation is about the type C, 1, 2, and 3, and this is the more comminuted distal tibial fracture. Classification also, you should be aware of open fracture classification, Gastello et al., 1, 2, 3, 3A, B, C, and you should be aware of churn, soft tissue classification, and this is very relevant here, but I didn't go into details because of the sake of the time. So this is not a bony injury, it's a combined soft tissue and bony injury. What's the history? So the history, the word Pillon, French word, means this pistil, الهون بالضبط كده بالعربي يعني. So this piston is the talus coming into the distal tibia, making this explosion. This is the word that came originally 100 years ago. Pillon fracture, up to 10% of the lower extremity fracture, up to 10% of the tibial fracture itself. Almost a quarter of them are open, and this means that there is a lot of energy there. Prior to 1960, poor outcomes led to more conservative management. After that, Rodi-Algor started the landmark series. What's the series that started the new era of fixation? So, 4 principles: anatomic reconstruction, stable internal fixation of the fibula, direct open reconstruction of the tibia, graft to support the defect, and rigid medial patrocity. These are the 4. And the original series yielded successful outcomes and 5% of infection. But this was, most of them were low energy, skiing, in Basel, treated in Basel in Switzerland. That's why this is very wonderful outcome. When this idea came to USA, these 3 guys reproduced the same study, and they found, wow, infection 35%, 25%. No, it's not 5% at all. So they had the ugly side of the Pillon. So what happened? Why? The whole idea about the timing of doing the internal fixation. That's why the early intervention ended up with more infection. And in 1999, 2 guys in the USA produced the staged protocol, which is span, scan, and plan. And this is the thing that we are still dealing till the moment with it. So you don't go for early internal fixation because this is very dangerous. Where are we? Elizarov guys. So they started in 1996. This could be the oldest one. This could be an earlier one, but it was in Italian, not in English. And this was the third one. These three guys used the ring fixator to reduce and fix Pillon fracture. And of course, they had almost zero deep infection. All this lecture, when I say deep infection, this means infection at the fracture site, fracture-related infection, deep infection. I don't mean pin site infection. And this is one of the dogmas, that we include the pin site infection as a deep infection at the fracture site. Pin site infection of the Elizarov, this is something different. So deep infection at the fracture site itself was very low, 0 or 5 in these three early studies. So what's the current? What happened after that? What happened after that? We have many studies, starting with the internal fixation, 2011, 49, and 2% deep infection. This is with more modern internal fixation plates and more soft tissue respecting approaches. 95 patients, early definitive, most of them with ORIF, and we can see that the closed fracture, very low infection rate, while the open fracture, 90%. And this is very honest and very true. We cannot bile open and closed in one thing, and this is one of the dogmas. So with open fracture, when you treat it with open reduction anti-infection, even after a while, there could be still higher risk of infection. Bigger series, 161, delayed staged versus acute, and 27% of deep infection. So again, acute fixation is not good. This was the conclusion of this specific study. They were all type C. With early fixation, we got more infection. So again, these are all predictive of failures. Another one, anteromedial versus anterolateral, and as expected, as shown from the first slide of the anatomy, of course, anteromedial give more skin problems than the lateral. However, some contradictory evidence say the reverse, but at least this is what we have from this study in 2017. Anteromedial could be problematic and higher skin necrosis. Again, bigger series, 135 direct anterior approach, and reoperation rate overall was 40%, including everything. So again, it's a viable option, but you should select your patient, and this is what we will discuss at the end. The Enforce study, it's a UK study, the biggest ever, 670 fractures. They looked how the hospitals in the NHS deal with the fractures, and they found 65% ORIF, fine wires only 13, some non-ring X-fix or IM. And again, they were not so happy about the management because only 57 of the articular surface followed the scan plan. So some of them, they just put in a plaster. And that's okay if you have a length stable fracture and no instability. You can put it in a plaster waiting for the surgery. But again, this study led to another ongoing one that hopefully looking at the outcomes, because at this moment, this study was only the service, how we are treating these patients. What about the external fixation? Do we have a relevant body of evidence to challenge the internal fixation ideas? This is the oldest limited fixator, not ring fixator, with the limited ORIF, 26 patients, and again, 1 deep infection, fracture-led infection at the site of the fracture. Same year, again, delta frame unlimited, and this option really is recently revisited in many studies. We didn't need the ring fixator, minimal fixation internally, and delta frame could be enough. We'll see, everything has its prerequisite, and again, 0 infection. And this is the whole strength point. Of course, there are pin site infection, but again, there is no deep infection at the fracture site. Lovisti, who is one in Italy, pure Elizarov guy, this was the earliest, again, 100% union rate and 0% infection. More and more ligament taxes with Elizarov, 17 patient, no deep infection, equivalent functional outcome. All these guys reporting only external fixation, only, without comparison. We are coming to the comparison in a minute. And again, this 2017 study, 56 patient, again, high functional outcome. And they started to say it's equivalent to ORIF. So we came from behind that Elizarov is good, then Elizarov is equivalent to ORIF. And this systematic review, which concluded all the previous studies, found that the deep infection rate is 4.8, and this is very good number to be aware of. Of course, there are some minor infections, up to 50%, but this is penside. This does not affect the final outcome, and this is not a fracture-related infection or a deep infection at the fracture site. What about the comparative studies? Because these are, we have many, indeed. Pillon fracture, type C, internal fixation or external fixation, and this is still an unanswered question, but I put some highlight. So this comparative study, they found no difference between them, between the both groups. Everyone has some culprits in the details. I will have a look in a minute about this. And this meta-analysis, 484, and again, no significant difference in the functional outcomes or deep infection. And this is very strange. How could deep infection comparable indeed? And again, I will show how this outcome reached there. Another meta-analysis with different inclusion criteria, ORIF versus Elizarov, and again, comparable, but the external fixator, fewer hardware removal, fewer infection. You should consider it as a viable option. Another one, 400 patients. You can see the disparity. This is the whole thing. We are not comparing equal number of patients at all. And even if we compare in next slides, you find that there are some culprits. 300 versus only 57. So the data should be cautiously interpreted. So that's why end up with X-fix significantly higher overall risk of post-operative complications. Again, this is something that needs to be looked at. Why? Because almost 97% of them were type 2 or 3. This was not the case in the internal fixation arm. And again, this is what we call selection bias. So there is some bias in the quality of the patients, and you conclude something that is not really related to what you have reported. In this expert consensus, they were discussing what's the best thing for between X-fix and internal fix, and they acknowledge that surgeon experience, this is a very good thing, host factors, and this is massively important point in selecting the patient for this type of fixation. As important as the fracture path. So it's not about the X-ray, not about the soft tissue even. Who will operate and what's the host factors? The active trial, we hope that this will end up with an answer because this is properly randomized controlled trial in the UK, still ongoing, 300 patients. This is the power that could end up in a very valid conclusions, and we are still waiting. What will happen? Do we have a final answer or no? Another comparative study included 133 patients, and the overall FRI was 23.3 in the internal fixation. And look at this. Interval more than 30 days is the strongest predictor of infection. So if you put a delta frame, wait for the skin, and operate after 2 months, you will get more infection. This landmark study defined that the safe period should be 10, 21, up to 30. Beyond 30 days, converting the X-fix into infixation is very dangerous. Last thing, and this is from Ain-Shams, from our colleagues, Dr. Gebeli and Dr. Baraka, and they had this RCT, 30 patients in each arm, and comparable, I will have a look into the depth of this specific study and few more. I picked 3 studies, frequently quoted, and they're very good. This systematic review, after everything, they found, again, they are comparable. But look at this line. Overall, there was a preference in treating more severe injuries with Elizarov. So we are not treating the same patient. You don't have 2 type C, 3 patients that you can put plate and screws, 2 or 3 plates and screws, or you go for Elizarov. We don't have this unique patient that can be treated by the both. So all the time, there is some bias. More complex patients with the Elizarov, less complex patients with the internal fixation. And then you draw conclusions. This should be taken carefully. This specific paper from my team in Liverpool, and they looked at their results about the fine wire fixation versus the Pillon. And again, deep surgical site infection was all right. Again, this is Liverpool. And they say ORIF with more than 2 plates is the predictor of more infection. So again, this is one message. 3 plates, 4 plates, no. More than 2 plates could be predictor of failure. And again, it's shared decision because the pen site infection could be problematic, but again, it's not a deep infection at the fracture site. The last study that I showed earlier, which is Dr. Mohammed Gabiri and Mustafa Baraka, and they did this RCT, but I highlight a couple of things before the conclusion of this study. Number one, they said that it's closed or open, Gastello 1 and 2. But here in this table, we can see that the open versus closed fracture in the Elizarov group, half of them were open versus 25% of them were open in the plate group. So again, we are not treating the same patient. And this bias could be taken into consideration when you take the conclusion. And the other thing, what about the infection rate? So they described the 3 infections in the plate. They are all okay. But when you look at the infection in the Elizarov, 4 patients, 2 of them had infection at the fracture site, skin necrosis needed flap. That's reasonably understand it. And another 1 deep infection. But 2 patients have pin site ring sequestrum after full union and removal of the frame. And they count this as fry during the treatment. And this should not be taken as this. The fracture united, no fractured infection at the fracture site. And after a few months, 1 pin site has a ring sequestrum. They do the debridement and that's it. So again, this number of infections is not true. So we have many systematic bias that end up me here standing defending on the Elizarov good, very good outcomes in terms of in comparison to enzyme fixation. The first one, the open and the closed fracture. They put all together, and again they put 1, 2, 3A, 3B, 3C. This is not comparable, and this is a very poor bias that end up with a conclusion that are not accurate. Bias number 2, the fracture type. Sometimes they include B and C, sometimes include B and C, 1, 2, 3, but you don't know really. Some of them, they don't give the full breakdown. How many patients were type C3, which we all know it's very challenging to put anti-fixation in? Nobody knows. So this is again one of the predictors, because with type C, 1 or 2 or 3, you will get more soft tissue injury. So every complication will be much higher. Third bias, the selection. Understandably, low energy, more healthy patients get internal fixation, and again, more soft tissue injury, more bigger blister, and bigger soft tissue hit treated with Elizarov. So again, they are not the same patients. Number 4, the infection classification, and this is really very annoying because they count pin site infection as deep infection. No, pin site infection is a very unique to external fixator. It's not there in the ORIF. But deep infection, as we all know from the consensus, this is the fracture site infection itself. Sinus, exposed bone, exposed metal, or whatever. But we cannot bile them, and many studies bile them, and many studies quote the same conclusion, which is not accurate. The last thing, which is the malunion. They all quote very historic malunion. Elizarov is not good in reducing articular surface. No, this is very old, because the modern technique that you can do either closed reduction, either many open reduction, reduce the fragments, put screws, put whatever, close the wound, apply the external fixator. This is the new, the recent ring fixator. The old ring fixator, they didn't open. They do everything closed. That's why they had some malunion. But with recent literature, malunion is almost none there. In comparison to the plate, I can see many malunion with the plate. Varus, valgus, rotations specifically. And anyone can easily fill in this. With X-Fix, you still got the idea to manipulate or do the proper alignment after the surgery. So, to conclude this, what's the predictors of failures? Because this is the whole thing. Host factor, diabetes, strongest predictor. For a diabetic man, 50 years old or whatever, and you go for double approach, double plates, no. It's a predictor of failure. It's a predictor of infection. Please think twice. Hypertension, smoking. Why would you have a patient who is diabetic and smoker and male sex, and you insist on doing anti-infection? No, choose the proper host. Age and BMI is not that independent factor, but again, take it into consideration. So the most important, diabetes, active smoking. The injury itself, high energy, of course, this is totally irrelevant. That's why we say we are not treating the same patient. The higher energy go for the X-Fix, the lower energy goes for plate. So they are not comparable. Open fractures, of course, open fracture will increase the risk, and we have many studies that reported this. Bullous and comminution. What about the surgeon itself? That's massively important. The delay more than 30 days, this is a predictor of failure. Operative time, more than 2 hours and a half. So think about, are you able to do the open reduction and fixation in less than 2 hours? Otherwise, there is evidence that is an independent predictor of infection. Post-operative glucose, intermediate approach, as the place that I shown in the beginning. So last thing, we are treating patients in Egypt, and as Prof. Al-Zuhairi said yesterday, Professor Osama Farouk, we are treating a little bit different patients, not as a human, but as organisms. What are the literature from Egypt about our current causes of infection? 2009, gram-negative in 70%. 2025, orthopedic infections, gram-negative, 76%. This is mine, 51%. So think twice. We don't have the MRSA first cause of infection as European countries which produced these studies. Conclusion. It's coming there. So decision making for Pillon fracture is very dangerous. Elizar fixator, it's always sold as severe soft tissue injury, unstable reducible fracture. You should obtain satisfactory reduction. But again, in our locality, this could be a very valid option head to head with internal fixation. Internal fixation, my only advice, remember these 3 predictors, 3 slides of predictors. Choose your patient. With good patient, with everything full, you will success. Otherwise, you will end up with failure. And this is our course about the bone infection. Hope that we can see you all. Thank you so much.